session, and joining me tonight is Sophie Tully. She's our Nutrition Education Manager. I think she's just going to say a quick hello.
Hi everyone, lovely to see so many familiar faces, as it were. Enjoy the webinar, and I'll be here at the end to help answer any questions.
Super, thank you, Sophie. Okay, so I think we've still got some people sort of coming in, but the first few slides are going to be sort of more of an introduction, really. So as I said, we are hygienists. We are experts in lipid nutrition. And if you're joining us tonight, then it's very likely that you would like to know a little bit about omega-3s and how they may be able to help your clients in regards to improving their health and possibly, in some cases, sort of managing some sort of health condition. So we know that there is a very strong link between omega-3 status, so the amount of omega-3s within our cells, and a strong link to poor health and certainly to a number of disease states, and it's usually sort of inflammatory driven. So we also know that if we increase our omega-3 intake and we increase the amount of omega-3s within our cells, we have beneficial health we have beneficial health effects, and they can be used therefore for both the prevention and the treatment of chronic disease. So as I said, tonight's webinar is going to be focusing on personalized nutrition, and the focus really is going to be trying to explain to you a little bit about how you can optimize omega-3 interventions for when you're treating your clients. So basically it's going to be how you can improve your clinical outcomes from fatty acid intervention by having a little bit more knowledge about your client and some of the factors that might be influencing how well they will respond to omega-3 supplements. So the first thing really is that we're going to sort of get to understand a little bit about the fact that we are metabolically unique. Then going to go on and sort of talk a little bit about why some studies produce inconsistent findings, and this relates through to why there's this sort of importance of applying to sort of personalized intervention. We're then going to talk about using biomarkers to identify personal requirements for omega-3 and how we can optimize their sort of clinical outcomes. And we're going to talk about the omega-3 index and the AA to EPA ratio. So for those of you who have attended these webinars before, you're familiar with it, but hopefully tonight there'll be a slightly different context. And like I said, so the whole purpose of this is to help you improve your clients' clinical outcomes using fatty acid interventions. So let's get started. Right, okay, so I guess really to appreciate the importance of omega-3 fatty acids in health and disease, it's kind of useful to understand the role that they play in maintaining our cell membrane integrity. So our cell membranes are compromised, sort of made up of fats, and they're made up in the form of phospholipid bilayer, and it provides a nice stable barrier between two aqueous compartments at the outside of the cell and the inside of the cell. I've just got a note there from Carolina. I think Sophie's going to maybe address that. Everybody else can sort of hear, I'm assuming. Everybody else's connections are good. Okay, right, sorry, I will continue. Okay, so so the cell membrane is incredibly important. The type of lipids within it are going to be important as well, because it's the changes in lipid composition that have functional consequences. So it's the fatty acid composition of our membrane lipids that greatly influence this membrane function. So we've got our lipid bilayer here, and we've got various proteins, and they need to be able to float around and be nice and active and functional. Okay, so our membranes generally remain fairly constant in regards to saturated fat and monounsaturated fat, and this is over a wide range of dietary sort of variations. And we know this because there are plenty of sort of animal studies that sort of back this up. However, the membrane composition is particularly responsive to omega-6 and omega-3 fatty acids. And most sensitive, in particular to the ratio of omega-6 to omega-3. So our saturated and monounsaturated stay relatively stable, but it's it's our intake of omega-6 and omega-3 that sort of influence the amount and fluidity and so on of our cell membranes. So why is this? Right, okay, so although we consume relatively large quantities of saturated and monounsaturated, we have the capacity to make them ourselves. So in regards to sort of plasma and red blood cell membrane contents, the levels don't necessarily correlate strongly with intake, so we make them ourselves. In contrast to this, we don't actually have the enzymes that are required for the de novo synthesis of polyunsaturated fatty acids, and this is why we have to consume them within our diets. And the long chain polyunsaturated fats are then synthesized from these essential parent fatty acids through a chain of desaturases and elongase enzyme mediated steps. And so here we have our sort of fatty acid sort of diagram that we can have a look at. So basically the purpose of this slide is to sort of highlight that when we're sort of talking about personalized interventions, the amount of fatty acids, omega-6 and omega-3 that we have within our cell membranes is mainly influenced by our dietary intake. So we can take in short chain fatty acids in plants and we can then convert them into long chain omega-6 and omega-3 fatty acids. But there's a huge individual variation in our ability to make them. And then obviously there's going to be variation in the type of foods that we eat as well. So whether we're eating animal products, whether we're eating plant sources of short chain fats, and again on the omega-3 side as well. When we look specifically at omega-3 fatty acids, so if we're looking at EPA and DHA, when we're looking at different people and the variation between their omega-3 content of their cells, for example, the majority of the variation can be explained by their intake of EPA and DHA through consumption of marine sources, so seafood and fish oils of fish, that kind of thing. So what we know is that people who have the highest amount of omega-3 within their cell membranes, it's likely that they're higher because they consume more fish or more marine products. So this leads us on to our next slide. So the significance of the membrane content of omega fatty acids becomes really apparent when we look at the antagonistic properties of the omega-6 and the omega-3 families. So we've got our omega-6 fats, DGLA and AA, and they give rise to end products. We've got EPA, we've got DHA, and they give rise to end products. However, it's actually the antagonistic relationship that is derived from arachidonic acid and EPA that really influences a lot of sort of health outcomes, if you like. So there's this sort of antagonistic relationship that's going on. So we've got DGLA, gives rise to anti-inflammatory products. We've got DHA, which is derived from EPA, primarily structural, but also gives rise to a few sort of anti-inflammatory end products. When it comes to the sort of accumulation of fatty acids within our cell membranes, our typical Western style diet favors the accumulation of arachidonic acid, and this causes huge problems. So it sort of drives something that's called the arachidonic acid cascade. So we give rise to highly inflammatory end products, so series 2 prostaglandins and so on. However, we can kind of rectify this quite easily, and we know this if we increase our intake of omega-3 fatty acids. What we do is through the inhibition of delta-5 desaturase by EPA, we can actually kind of switch off the capacity for DGLA to convert to arachidonic acid. So we have this kind of major shift from pro-inflammatory to anti-inflammatory. So we get nice, healthy anti-inflammatory products and from EPA. Now, at this point, it's quite important to just sort of emphasize the fact that DHA important structural fatty acid, but it doesn't have the same kind of antagonistic relationship with the omega-6 way that EPA does.
I'm just going to
Okay,
butt
so
in
if we're
for a
talking
second, Nina.
about
Sorry.
biomarkers, we're talking about
Sorry, Nina. Just to let you know that there does seem to be something a little bit funny with your microphone. I don't know whether it's a dodgy wire, but if you could just give everything a little bit of a wiggle because you faded out there for a minute. Might have just been for me. I don't know if anybody else had the same problem, but just give everything a wiggle and then carry on because you came back and everything was fine.
Okay, I'm wiggling.
Splendid. Yep. Good. All seemed well again. So
right,
if you
okay.
just make sure the microphone's nice and close to your mouth, then that will hopefully help. Splendid. Carry on.
Should be here. Okay, so we're talking about biomarkers and we're talking about the AA to EPA ratio and the sort of antagonistic relationship that there is. And so if we can find out what the AA to EPA ratio is, it gives us a really valuable information on the inflammatory status of an individual. And what we know is that you can restore a healthy inflammatory profile using pure EPA. And I'll talk a little bit about sort of the use of pure EPA rather than EPA and DHA blends, and sort of clarify that a little bit a bit later in the talk. So clarifying our biomarkers. So I've just kind of highlighted the sort of importance of fatty acids and sort of intake and the balance and everything. So we end up with these two really useful biomarkers. So we've got our AA to EPA ratio. So we've got our omega-6 and our omega-3, but we've also got our omega-3 index, which again, I'll go into a little bit more detail in a moment, but it's the amount of EPA and DHA that's found within our cell membranes, and combining these two together gives us really useful information about the status of a person's health. So our to EPA ratio. Okay, so if we have a quick look at this, so we've got a nice diagram here. So we've got 0 all the way through to 20, and this kind of goes off the sort of side of the picture here. Early sort of studies showed, and this sort of stems from those sort of Inuit studies that were performed or sort of gathered data from sort of 40, 50 years ago now, where it was observed that Greenland Inuits had very low levels of inflammatory disorders, and we got a lot of really useful information about omega-3s from those studies. So we learned about the omega-3 index, we learned a lot about EPA, and we also learned a little bit about the AA to EPA ratio. And what was found was that Greenland Inuit, low amounts of inflammatory disorders, actually had an AA to EPA ratio that was less than naught, which is really unusual. Japanese populations, again, sort of attributed to sort of high fish consumption, generally have a AA to EPA ratio of about 1.5 to 3. So it's a nice kind of healthy balance, implies a nice balance of anti-inflammatory to pro-inflammatory end products. But if we look at our Western population, so we've got sort of Europe, the UK, and certainly sort of going over this side even more, we've got the USA. Our AA to EPA ratio starts to rise and rise and rise. And then when we get to sort of levels of 20 and upwards, there are some really nice that are using the AA to EPA ratio as a disease biomarker. And in fact, for anybody who's attended one of my talks before, I've kind of discussed this in a little detail. That in regards to sort of cancer, the AA to EPA ratio is being used as a bit of a diagnostic tool to monitor state of progression of a tumor within the actual tumor site, sorry, the sort of disease site, sorry. So so it's being used as a really sort of valuable sort of diagnostic tool. And in fact, when we look at the products derived from EPA and the end products that are derived from arachidonic acid, the importance of these compounds actually in health and disease and the sort of progress of health and disease is evident from the huge range of pharmaceutical products that actually target biosynthesis or the action of those eicosanoids. And it's the eicosanoids primarily that are derived from arachidonic acid metabolism. So AA metabolism is the direct target of drugs such as non-steroid anti-inflammatories. We've got COX-2 inhibitors, we've got COX-1 inhibitors, we've also got leukotriene antagonists. So anybody who's sort of got asthma, for example, who uses one of the sort of pumps, that right, okay. If you bear with me, Marion, I'll just clarify your question. Maybe at the end of the talk, we'll sort of address some of the questions here, and you can ask a sort of question, maybe a little tail. But these are a lot of drugs that are targeting arachidonic acid metabolism, and we can actually intervene in the arachidonic pathway at various sort of steps. So even as far as back as looking at the phospholipid bilayer, the first step to the production of pro-inflammatory products is the release of arachidonic acid by phospholipase A2. Arachidonic acid or free arachidonic is then allowed to convert through using either COX or COX-2 into the next sort of series of prostaglandins. So we've got prostaglandin H2 here, and then this drives through to pro-inflammatory products. And we number, I mean, the amount of end products that are derived from arachidonic acid double figures quite easily. So this is just to give you an idea of just some of the end products. So we've got thromboxanes, we've got leukotrienes, we've got a series of prostaglandins, huge amount of end products. They're all pro-inflammatory. And these are the targets for a lot of pharmaceutical drugs, for example. The nice thing is that if you increase your EPA intake and you get a nice balance of AA to EPA, EPA actually downregulates phospholipase A2, so it prevents arachidonic acid release. It actually shifts arachidonic acid out of the phospholipid bilayer. It competes for COX-2, it competes for COX-1. So lots of interplaying going on here, but just increasing EPA has a really strong anti-inflammatory or a range of anti-inflammatory benefits at various sort of aspects of the arachidonic acid cascade itself. And then when we sort of think about how inflammation plays such a vast role in driving so many of these sort of inflammatory related conditions, we can start to see the AA to EPA ratio and managing the AA to EPA ratio. It's not surprising that we see so many sort of avenues for sort of therapeutic intervention. We quite often get asked, well, why pure EPA? You know, there's a lot of fish oils or fish oil concentrates out there, but why do you target pure EPA as the sort of first part of your sort of restore and maintain treatment protocol? And simply, and this is some slides that are taken from one of the Jellis papers, but when you administer pure EPA, what happens is that you get a decrease in cell membrane arachidonic acid, and this reduces the production of thromboxanes and prostaglandins. So these are inflammatory products, and this is particularly in relation to sort of cardiovascular disease. So thromboxane A2 is a sort of vasoconstrictor. It increases platelet aggregation and so on. And it's this relationship. So we also get an increase of prostaglandin 3 from EPA. And so we get this reduction in inflammation and inflammatory end products. So here we've got our sort of balance here. When you supplement with EPA, thromboxane and the prostaglandin ratios all change. And it's the improvement in this prostaglandin to thromboxane ratio that is significant when we administer pure EPA, because when you administer pure DHA. So when you give DHA, what basically happens is that to some extent it will decrease the amount of arachidonic acid within cell membranes, but not quite as effectively as EPA. But you don't get the decrease in thromboxane A2 and prostaglandins that you do when you compare it to EPA administration. So in it, you don't get the prostaglandins that are produced by EPA because DHA doesn't produce prostaglandins. And so the whole kind of improvement of this prostaglandin-boxane ratio is therefore almost insignificant if you use DHA as it would be if you were to compare it with EPA. And in fact, if you actually look at the study that these little sort of diagrams came from, JELIS study is one of the sort of largest cardiovascular studies recruiting over 18,000 people, and they recognize the importance of the sort of EPA DHA ratio when we're talking about sort of interventions for inflammatory related conditions. They found that 2 grams of EPA in individuals with high cholesterol resulted in significant reduction in the risk of coronary events when the AA to EPA ratio was reduced to less than 1.4. And this reduction in AA to EPA ratio was associated with an additional 90% reduction in cardiovascular events over the next 4.5 years. So this is one of the sort of big pure EPA only sort of dietary interventions, and there is more and more and more of these cropping up as our sort of knowledge science behind pure EPA as an anti-inflammatory and in one of my previous slides when I was talking about the use of the AA to EPA ratio in as a diagnostic tool for cancer, for example. This is a nice slide taken from 2013 review, and it's really highlighting the antagonist properties between or that arise from AA to EPA ratio, AA to EPA in regards to sort of pro-inflammatory and anti-inflammatory effects. So if we think cancer, there's so many kind of influences behind there, but inflammation is known to be sort of the driving force behind tumor progression. So we've got things like proliferation, we've got migration and invasion, we've then got angiogenesis and so on. And we know that AA is the driving force and EPA is the fatty acids that's going to dampen these. So high AA to EPA ratio, and you've got increased cancer risk, cancer progression, lower your EPA ratio, and we get a reduced cancer risk, reduced cancer progression, and especially if we can reduce the AA ratio in the cancer site itself or in the tumor site itself. So huge amount of promise there for the AA ratio. Okay, so back to personalized intervention. So we've got our AA to EPA ratio as a really useful biomarker, and it gives us really good, strong information about our inflammatory status. However, as I've mentioned, diet has the capacity to influence the amount of polyunsaturated fats within our cell membranes. And so whilst our AA to EPA ratio may appear to be nice and healthy, it might appear to be nice and balanced, we still need to ensure that we've got adequate amounts of actually both fatty acids. You need arachidonic acid and you need EPA. You just need them in relative amounts, and you need a good ratio of the two. So it may actually just be that your AA to EPA ratio appears healthy, but still your omega-3 levels may be low. So this is when we sort of bring in the omega-3 index, because this has features that qualify it as not only as a biomarker of intake, so we get really good information about how much omega-3 we're actually eating and digesting and incorporating, but we also use the omega-3 index as a really good risk marker. And recent sort of indications are suggesting that it's a really good risk factor and therefore a target for therapy in itself. So IGENIS combine the AA to EPA ratio with the omega-3 index, and this gives us a good, strong, comprehensive overview of our health status. So yeah, okay, so there's just a really kind of graphic sort of to highlight the omega-3 index. So I mean, this goes back to 2004. So the omega-3 index is the total amount of EPA and DHA within your cell membranes expressed as a percentage of the total amount of fatty acids. And it was originally developed as an informative risk factor for the development of cardiovascular disease. And if you look up the omega-3 index, most of the sort of references that you'll find will sort of relate it through to cardiovascular disease, although more studies are sort of coming through that the channels showing that the omega-3 index is related to things like mood disorders, body composition. So there's sort of avenues for sort of treating metabolic disorders, diabetes, and so on. But really nice and clear is that we need to be looking at an omega-3 index of more than 8%. And we know that 4% is recognized as an undesirable level. And here we have some of the evidence that was sort of used to or used in the development of the omega-3 in the epidemiological studies, with some dietary intervention studies, monitoring omega-3 levels, and individuals with levels of 4% were shown to have least protection against cardiovascular events, whereas individuals with 6% up to 10%, and obviously as it's getting greater, you get the greatest protection. So need to be driving an omega-3 index of at least 8% and target 10% if we can. And so that's it. This is all great, isn't it? So we know that a nice high omega-3 index of 8% is really health positive, right? And that's all kind of derived from sort of epidemiological studies and some dietary intervention studies. Okay, so high omega-3 intake, so be it fish, marine products, or fish oil, increases our risk of disease. Great. Okay, so raising the omega-3 index as a therapeutic intervention for cardiovascular issues has been the focus of many large intervention studies. However, in contrast to the evidence that is provided by the epidemiological data, the intervention trials are coming back with neutral findings. And this is kind of raising sort of questions of, well, do fish oils actually really work? So yeah, we're sort of getting a lot of questions going on. So what is actually going on? Why aren't they working in dietary intervention studies? And this is really the kind of the crux of this talk tonight, because today, or so sorry, right now, we're going to talk about why fish oils sometimes fail and explore some of the ways that we can actually improve some of the sort of variables that are influencing the outcomes of these studies. Now, this is taken from a really nice paper published this year, actually, by Clement von Schacke, and he really highlights some of the indiscrepancies that are arising that are causing some of these sort of neutral findings. The first thing that he addresses is that the majority of the studies actually use omega-3s that are of low bioavailability. Now, when these studies sort of first kicked off many moons ago, there are only so many supplements that you can sort of choose from, and the original studies really used a form of omega-3 in ethyl form. Now, we've known for a long time that the bioavailability is a little bit reduced. However, what we do know is that if you take ethyl ester with fat or with a high fat meal, you improve the bioavailability by about 13 times. So the first thing he points out is that a lot of the studies use an omega-3 that is not very bioavailable. Okay, that's fine. You just take it with a fatty meal, not a problem. However, when he started sort of looking a little bit more closely at the recommendations that were given by the researchers to the participants, what he found was that the actual time that they were told to take the fish oil capsules was in the morning with breakfast. Now, this may not seem like an issue, but a lot of the sort of European countries that this come from, the breakfast is actually the meal of the day with the amount of fat. So quite often it's not a fatty meal at all.
even sometimes in some cases, people don't have breakfast at all. So not only do you have a low bioavailable form of omega-3, but also you're probably not digesting it and you're not absorbing it. So the chances of fatty acid getting into your cell membranes, which is where it's needed to sort of elicit its benefits, is reduced. Another really important factor that he addresses is that study participants were often recruited irrespective of their baseline levels of EPA and DHA. Okay, so and I'm going to do this again in a minute about the importance of baseline level, but for now we'll just sort of cover this. He also points that not only are they recruited irrespective to their baseline levels, but they're actually then treated with fixed doses. So this ignores. Okay, sorry, Lynn. Let me tweak my connections again. How's that? Oh. Okay, if I carry on talking, how's this? Sorry about this, guys.
Yeah, no, sorry, Nina, you have faded out again quite badly. So just keep wiggling
Right.
and keep talking. I'll let you know when you're
how's
back
that?
in.
Can you hear me
It's
now?
got quite quiet. You haven't moved your microphone, have you?
How's that?
Yeah, perfect. Can everyone else hear? Is that better?
Okay, right,
Great.
okay. Was fine before, good now. Super. Okay, right. So we've got low bioavailability. We're not taking our capsules with a fatty meal. We're recruited irrespective of our baseline levels, treated with fixed doses, and this kind of ignores the large individual variability in the uptake of EPA and DHA. So what is known is that with the majority of individuals, people with the lowest omega-3 levels tend to be the best responders when it comes to fish oil supplementation. And all of these sort of like factors, all taken into account together, Clement von Schacke says these factors can explain the tendency towards a lot of the neutral results that we find in many intervention trials. And in fact, when I'm sort of doing my research, what I find is that these factors are coming up over and over and over again, and researchers are saying we need to be addressing a lot of these factors, especially things like baseline levels, because there is so much there is so much variability in how people respond to fish oil supplementation that it's not surprising that we're seeing differences in the Another important factor to just mention very briefly is that not only do baseline levels of fatty acids differ between in healthy individuals themselves, but actually they differ between healthy and non-healthy populations. So this is, in brief, just a study that I found published in 2014, and this group looked at the red blood cell fatty acid, EPA and DHA, and arachidonic acid in healthy individuals and in a group of different disease populations. So they looked at cancer, they looked at psoriasis, social phobia, and intensive care unit trauma patients. And they will really see how the baseline levels of omega-3 affected the incorporation of the omega-3 fatty acids after they'd taken the supplement. And the significant findings were that there were significant differences to start with in red blood cell membrane, the populations. They found, unsurprisingly, I guess, that the healthy populations had the best levels of omega-3 and they had the most favorable omega-6 to omega-3 ratio, and you'd kind of hope that that would be the case. But what they really found that was really important was that the treatment associated changes were totally dependent on the initial omega-3 levels themselves. So how people respond to a treatment depends on what their baseline levels are. Kind of makes sense, really. Right, okay. And another factor that's really, really kind of coming out, and researchers are saying, okay, so we didn't quite get the results that we were expecting. But what we found in our study was that most of the participants didn't actually, their levels didn't rise to 8% or over, and we recognize that this is the level that is needed to obtain clinical efficacy. So with some people, especially if their omega-3 levels are really low in the first case, if they're being supplemented with a fixed dose, regardless of that, they may never actually reach a level that is going to be clinically effective. And so there's this huge focus on ensuring that we reach this sort of ideal omega-3 index of around about 8 or higher if we can. Okay, so if we know baseline levels, we can guide practitioner recommendations, or we can guide our own recommendations. And we know that, and again, not surprisingly, low baseline values may require larger doses. It just goes without saying that if your levels are low, you might need more. And so we actually use the omega-3 index as a really useful way of assessing both our baseline risk and our change in risk as a function of intake of our omega-3 fatty acids. And again, dose response studies show us that high doses of omega-3 are generally required to achieve an omega-3 index of more than 8%, especially so when the baseline levels are suboptimal. So if levels are less than 4%. And guess what, guys? The average omega-3, and I've got a couple of slides showing very sort of similar results, really. So it's quite common within the UK. It's common, certainly within Europe. Oh, Marion, is anybody else hearing me? Sorry. It's all good. Okay, I'll carry on. Okay, so the highlight, the crux of this slide really is to highlight the huge variability in people's red blood cell membranes. This is sort of just a general population. Okay, so the lowest omega-3 index is 2%, the highest is 7%, and our average is only 4.3. So this population of people, the average amount of people, actually were almost suboptimal. Nobody reached 8%, and that's the kind of area that we should really be concentrating on. So within the same study, they divided up the population, and we see a nice dose response in response to our omega-3 intake. So people were randomized to take either no fish oil, 300 milligrams, 600 milligrams, 900, or 1.8 grams. So we have our these are our baseline levels, so they're quite similar, about 4.3, 4.2, and then post-treatment. So a nice steady rise from 4 to 6 to 6 to 7 to 9. 1.8 grams obviously gives us the highest increase, and then our levels here is the change in the omega-3 index. So we can see that there's quite a good increase in response to a sort of dose response. But this slide really goes to town when we're talking about really clarifying the huge variability in people's response to supplementation. So here we've got, this is our change in omega-3 index rather than the omega-3 index. So these are the figures from the slide beforehand. So this is the change. So we've got 1.8, 2.5, 3.2, 5.9. Each of these individual diamonds is a person. So we've got Arch going through the middle, but the way that people respond. So this guy here, he was taking 1.8 grams, but his change in omega-3 index was really quite insignificant compared to this. I say guy. I should be a little bit less sort of male female, but this person, sorry. Okay, so this kind of really highlights the huge variability in the way that people respond. And part of the purpose of this study was really to sort of highlight some of the variability and what was influencing. And the researchers reported that baseline omega-3 index, age, sex, and physical activity were all influencers. But of all the variables that had the biggest influence was body weight. And again, this isn't really surprising when you kind of consider that, we're all different in sort of shapes and sizes, and somebody of sort of a 90 kilo person is probably going to need more omega-3 than somebody who's a 50 kilo person. And that's sort of assuming that their omega-3 levels are at the same level at the start of the sort of study. So there's a lot of positive things to take away from this. And this, as I promised, is another little slide just to show you the huge variation in people's response to fatty acid supplementation. So this time we've got 40 individuals. They all had an omega-3 index starting value of less than 5. So you can see it's quite balanced all the way through. Sorry about that. And then after 6-week intervention with half a gram of omega-3, we see a mean rise from 4.37 to 6.8. Excuse me. But again, huge variability. So this went up to nearly 12, whereas some of these people hardly responded at all. So it's really to sort of highlight we are all really different. Cannot treat everybody the same. And again, this is just another little sort of study here. So again, average omega-3 index at baseline was 7.3. 120 days with 1 point of omega-3, we rise to 7.3. That's nice. We assume that sort of intervention is going to increase our omega-3 index, but again, our baseline range anywhere between 3 and about 11, the treatment range 3.7 to 13. So that should really kind of highlight through a few studies and the fact that we are all very, very different in the way that we respond to fatty acids. So the purpose of this really is to highlight that if we want an omega-3 supplement to have clinical effect, it has to be able to increase the omega-3 index to a level that is deemed effective. So we've got issues in regards to our baseline levels, how much we actually need, how much our condition or disease state requires. And for practitioners, we don't have the benefits of being able to have access to things like Omacor or Baskeeper. So Omacor is an EPA DHA ethyl ester. Baskeeper is a pure EPA ethyl ester. We don't have those, so we are restricted, if you like, I guess, to non-pharmaceutical products off the shelf. And as general practitioners, or if you're practitioners like yourselves, unless you have access to wonderful nutrition scientists like Sophie and myself here at iGenis, you're kind of quite blind sometimes in the way that you're maybe dosing your clients. And this is because a lot of the non-pharmaceutical products that you can sort of take off the shelf will variably, not only in their omega-3 content, but also in their form of delivery. So we've got our standard fish oil, for example, and triglyceride, we've got krill oil, phospholipid, and then we've got our omega-3 isolates, and these are the ones that are really clinically effective because they're the ones that are going to deliver the maximum amount of omega-3. But the point is, not all supplements will deliver therapeutic doses, and so you practitioners have to choose wisely. Oh, here we go. So this is our, just to sort of highlight. So this is our ethyl ester. This is the form that most of the sort of dietary intervention large studies use. We now have sort of progressed to the point where we can take our fatty acid, which is derived from a natural triglyceride, or you find it in a phospholipid, and we can re-esterify it back into its natural triglyceride form. And by doing this, we increase the bioavailability because we put the old glycerol backbone back on. So the digestibility and the incorporation into cell membranes is a lot more effective. So now I'm going to talk about how to choose a supplement and how to choose a supplement that's going to work, because the whole purpose of taking an omega-3 is you want to raise your omega-3 index, and you want to lower your AA to EPA ratio. And so your supplement has to be able to do this in order for your client to experience clinical benefits. So this study really highlights the diversity of the supplements that are out there and what the manufacturers tell you their products will do. So this was a very recent publication, and these guys, they took 4 standard off-the-shelf fish oil supplements, if you like. So we have a concentrated fish oil, re-esterified triglyceride. So this is a full, highly bioavailable form of omega-3. So it's got its glycerol backbone, highly bioavailable. We've then got our concentrated ethyl ester. Now this is the form that I'm talking about, that is found in pharmaceutical products and used in clinical trials. And then we've got our standard salmon oil, so it's a standard fish oil, fish body oil. And then we've got krill oil. Now you're probably all familiar with the huge amount of hype that is associated with krill oil, with its massive bioavailability. You've got Carol Vorderman telling you that you only have to take 1 a day. But if we look at how much EPA and DHA we get, and what's important here is this is the amount of EPA and DHA in a dose as recommended by the manufacturer. So, so these are either 1 capsule or 2 capsules, and this is the amount of omega-3 you're getting. So if we think back and we say, right, okay, we need large doses of omega-3 from evidence from our dose response studies, we have to have a capsule that's delivering a bioavailable form of omega-3. We also need to have a capsule that's going to deliver a relative amount of omega-3. So what happens when we supplement with our 4 different products? Okay, well, it's not actually really very simple, to be honest. So our RTG product, which, to be fair, had the most omega-3 in it, increased our omega-3 index significantly. We then have our ethyl ester form, which also had a good impact, had slightly less omega-3 in it. And then, of course, we have our salmon oil and our krill oil, which contain relatively low levels. If we go back, so we've got 400 and 240 respectively. So it's not really surprising that dosing in guidance with the manufacturer, you don't really see a huge impact on the omega-3. When people are advised to take a fish oil and then they go and buy something off the shelf and they may be choosing salmon oil or they may be taking krill oil and then they don't see the benefits, it's really down to the fact that these products are almost incapable of raising your omega-3 index unless you're taking them in super mega high doses. Okay, so next slide. What happens when we supplement to our EPA ratio? So again, as we would expect, those fatty acid supplements that contain the highest amount of EPA and DHA have best impact on the AA to EPA ratio. Now, what's quite interesting about this slide is that the amount of EPA and DHA within our re-esterified fish oil and our ethyl ester fish oil was different. So our concentrated RTG product had more omega-3, but our concentrated ethyl ester had more EPA. So it's this antagonistic relationship that occurs between EPA and AA that results in a better outcome when we're looking at decreasing our AA to EPA ratio. And again, so we've got our fish body oil and we've got our krill oil. They do have some effect, but it's not nearly as significant. So if your client is coming into you, they want to see clinical benefits from your products or the products that you're recommending as soon as possible. And so the importance of bioavailability and delivery really sort of impact and become quite important here. Okay, so if we then look at the study in a little bit more detail, one thing that's worth pointing out is that we've talked about RTG and about ethyl ester, all these individuals were advised to take the supplement in exactly the same way, and it's just interesting to see if the ethyl ester supplement had been taken with a fatty meal, then the incorporation into red blood cells may have been similar to equal to that of the RTG supplement. Something else to really kind of is that the dose of 1 gram of the reesterified triglyceride, 28 days, raised the omega-3 index from 4.1, which is a high risk, up to 6.8, which is a lower risk, but it's failed to reach this desirable target value of the omega-3 index that we've set at 8% or more. Okay, so krill oil, standard triglyceride oil, used at manufacturers' recommendations, failed to have either a significant impact on either the omega-3 index or the AA to EPA ratio. So form and dose, really, really important. Now, if we take the length of the study trial into account and the dose into account, and we go back to the study that I mentioned previously by Flock, so this is the dose response, and looking at the sort of the variability in incorporation between people. Flock highlights in his study the importance of body weight, so if we recall that. Now, the study that I've just mentioned, the average weight was 77 kilos. If we take into account body weight as highlights, we know that in order for a 77 kilo person to raise their omega-3 index from the 4.2 that we saw to the 8%, they would actually need, if we can work it out, as a daily dose of 16 milligrams per kilogram per day, which is the equivalent of about 1.25 grams. So if we then compare that to the actual doses that were obtained from these fish oils, you can see that the concentrated RTG and the EE both gave rise to milligram per kilogram, effectively quite close to the 16 milligram target. And just at the bottom to sort of highlight, this is our fast store, which is also 30 milligrams per kilogram. But salmon oil and krill oil really just don't cut the mustard. So 5 milligrams per kilogram and 3 milligrams per kilogram. So the purpose of this, again, is to go back to sort of like personalized dosing. So simply put, a 77 kilogram person would need a little bit more than the amount that they were given. If they had been advised to take it according to their body weight, then it's likely that within 28 days, maybe a little bit longer, they would have achieved an omega-3 index target value of 8%. And where we sort of really sort of interject here and highlight the bits of taking the Optio3 and how we can use these biomarkers for personalizing omega-3 fatty acid dosing to maximize the chances of clients seeing benefits to actual dosing itself. So, sorry, it's a simple blood biomarker. Take some blood, send it to the lab, come back, you get your omega-3 index, you get your AA to EPA ratio, and then you get a personalized plan which delivers an omega-3 index to a target range of 8% to 10%, and we reduce our AA to EPA ratio to between 1.5 and 3. And just to sort of highlight the fact that it does actually work, this is a slide that I've actually shown before, but this was just to really highlight that this person came in, their baseline levels, omega-3 index was 3.5, AA to EPA ratio 8.52. According to their body weight, based on their baseline levels, they were advised to take 1.5 grams, and after 4 months, omega-3 index significantly improved, AA to EPA ratio significantly improved. So as our omega-3 index rises, our AA to EPA ratio goes down. So it's all good stuff for health outcomes. Okay, so I'm kind of coming to the end of the webinar today. So I'm just going to put a few slides in to really sort of highlight the benefits of understanding the importance of knowing our sort of baseline levels and how we can use this in practice. So this, I've talked about cancer as well. So this is just a quick slide to sort of highlight the use of omega-3 as an intervention for women at high risk of breast cancer. And it shows a really nice dose response. So how breast cancer is that high consumption of fatty fish is associated with a reduced risk. Intake of omega-3 fatty acids from fish is inversely associated with breast cancer risk. So it's all good. So here we have our dose response. So individuals given 3 grams a day, and what we find is that the omega-3 index, as the omega-3 index rises, so the light green is the omega-3 index, and the light green is the omega-3 index, and the dark green is the AA to EPA ratio. So as we go up, our AA to EPA ratio comes down, and so we just see this really nice relationship between the AA to EPA ratio. Okay, and then another quick study that's of quite importance as well is again to highlight the sort of importance of using pure EPA in sort of treating inflammatory disorders, and especially where there are sort of issues with high levels of arachidonic acid. So talk about colorectal cancer for just a second. Standard treatment that is used to identify and remove bowel polyps, which is the sort of the very early signs of colorectal cancer, is through a colonoscopy. You can then remove the polyps, which reduces of bowel cancer, but it's not 100% effective at preventing bowel cancer itself. So we've got a little polyp here. Normally they just get snipped off, but it's not actually that effective at preventing bowel cancer. The primary aim of the seafood polyp prevention trial is to determine if 2 grams of EPA daily, as re-esterified tried, actually prevents the development of colorectal adenomas. And this is either alone or in combination with aspirin. So it's really useful because it's non-invasive. And one of the sort of big issues with colorectal cancer is people get really embarrassed, they don't want to, so they sort of put everything on hold. So if people could just take nice, highly concentrated EPA fish oil and that kind of did the job, then that would be really wonderful. So the purpose of this trial, and this is ongoing at the moment, is to address the question, is EPA an effective way to reduce bowel polyps and so reduce future bowel cancer risk? So as it's an ongoing study, and at the moment the participants being recruited are on average between about 55 and 73 years old, and they've been identified as high risk. And the intervention, in brief, comprises of 2 grams of EPA a day, a split dose over a period of 12 months. And we're hoping sort of that some results will become flying in within the next couple of years once it's. So this, just a bit of background as well to go back slightly, sorry. The use of EPA in very early human intervention trials has been shown. It's been shown to reduce polyps in animal models. So we're now at a sort of phase 3 intervention study, and we're very proud to say that we are the providers of the EPA for this study. So if we can just highlight, so we talked about some of the risks or some of the issues that we've got with some of the intervention trials and issues that we have with the fish oils not working. So what we can say about this study is that we are improving intervention. So not only are we using RTG, so we're sort of going really high bioavailability, can't get any more bioavailable, but you're actually using EPA, a dose that is effective at increasing the omega-3 index, and the study period as well. 12-month intervention, we know that that's long enough to see an effect. Whilst we're not actually, or whilst I said we researchers aren't actually at the point at the moment to address the omega-3 and then dose accordingly. So everybody everybody in this study is just getting 2 grams a day, regardless of their omega-3 index baseline levels. What the study is doing is it's addressing the omega-3 index. So they're taking the actual levels, and they're looking at the AA to EPA ratios. They're taking the baseline, and they are looking at the same biomarkers at the end of the intervention period. So what they'll be able to do is identify. So for those individuals who this intervention works for, and there'll probably be individuals who this intervention doesn't work for, and they can actually sort of correlate it and look at it a little bit more closely and see if baseline levels of omega-3 index, the baseline levels of EPA and AA are actually significant. So it's a nice sort of study that is addressing some of the issues that we're seeing in regards to the sort of the uniqueness of us as sort of metabolic, or the metabolic uniqueness of us all as sort of individuals. Okay, so I'm now going to summarize, and then hopefully there'll be some nice questions for Sophie and I to answer. And I found this webinar interesting and useful, and that you'll be able to take some information away from it and put it into practice with your clients. So really, to sort of summarize, is that we know that there are some human intervention studies that show inconsistent findings, and that these findings are explained in part by things like poor bioavailability of fish oils. There's huge variation in people's baseline levels, as well as other factors that are associated with variability. We know that dose response studies shows that high doses of omega-3 omega-3s are generally required to achieve an omega-3 index of 8%. And we know that there is huge variability in the way that people respond to supplementation. Researchers are addressing these factors more and more. And as I said, as I'm reading, this is sort of coming out in the discussions more and more and more. People are saying, you know, we need to sort of identify, we need to take these into account when we are designing studies as well. So acknowledge the fact that not all oils are the same as well. Acknowledge the significance of the bioavailability on its ability to reach an omega-3 index of 8% and to reduce the arachidonic acid to EPA ratio to less than 3. Knowledge of baseline levels will help guide you to recommend, because we know that low baseline values may require much higher doses. Monitoring levels as well, this is really important as well. Just because we know what's going on at the start of the intervention, there may be other issues. So if you monitor routinely, so we actually suggest every 6 months, this can identify issues probably with compliance. Are your clients taking their omega-3s? But it also helps to identify their progress, because if they're not progressing, if the oils aren't having an effect on their omega-3 levels or the AA to EPA ratio, there may be absorption issues that you maybe need to be looking at as well. But really, the whole kind of concept is that we should be focusing more and identifying the need for personalized omega-3 fatty acid dosing for clinical outcomes. So at this point in time, I'm going to say thank you very much, everybody, for taking your evening out to listen to us tonight. If you'd like to ask any questions, then we will be quite happy to answer the questions. I don't know if, are you going to come and join me, Sophie?
I am. I'm back. Hello. Thank you very much.
You'll have to forgive me because I'm getting a little sniffly, and I'm aware that I might be sniffling into my microphone.
That's all right.
So my apologies.
That's okay. I'll rescue you from the sniffles. Excellent webinar, Nina. As always, thank you very much for that excellent scientific overview. I think it's a really poignant area, and obviously we at iGenis are privileged that we can spend researching and reading and understanding this area, because there's so many different marketing messages out there. But for me, the really key points are that you have to get your omega-3 into your cell in order for it to actually work. And we can also directly use biomarkers that tell us what's going on at a cellular level to not only predict disease risk, but help us to understand response, who's going to respond, how likely you are to respond, and exactly how much omega-3 you really need. So it's important, as you clarified, to make sure that when you are using an omega-3 intervention, you know what the person needs, you know how much they need, and you choose an oil that's actually going to get into the cell and deliver those biomarker results that are expected and necessary for results. So we've had a few questions, and I'll kind of mediate these for you, Nina, but if you want to take over and answer them, please jump in. Just a few. Firstly, just going back to what Marion asked earlier on, whether or not, or who is using the AA to EPA ratio. As hopefully many of you saw in the chat box, it is very, very widely used in research. So all you need is a quick search on any medical research database, any scientific paper publication database, and you'll see that if you type in AA to EPA ratio, it comes up in all sorts of areas of health, not just in animal studies, but as Nina's shown, in cardiovascular health, in cancer, and colorectal issues. So it's very, very widely used. But do feel free, if you've got any specific questions or you want any specific papers, to get in touch. Then we had a question just now from Holly, which Nina, you're perhaps best placed to answer, as to whether or not you can overdose on fish oils.
Okay, so can you overdose on fish oil? Well, there are certain side of experience if you try to overdose on fish oils, and the first would be that you would get incredibly loose stools, maybe some sort of gastrointestinal well, but that's probably not really what you're asking. The answer is that it is likely that at some point, it depends on, I guess, also what you mean by overdose, how much is too much. If we go back to one of my very early slides when I'm talking about the AA to EPA ratio, and I showed you my little diagram and I mentioned the Inuits. The Inuits very famously were sort of remarkable in just how much omega-3 they actually consumed. So they weren't consuming things like fresh veg every day. They were just living literally on sort of fish and marine and whale and seal, and their intake of EPA on its own, so not just omega-3, but EPA on its own, was as much as 13 grams in some cases. So I can't really see many people sort of going for the 13 grams as a dietary intervention. I probably wouldn't recommend it myself. And the benefits seem to sort of outweigh the risks, certainly for the Inuits. But to some extent, it's about getting a we kind of give arachidonic acid a bit of a bad name when it comes to inflammation, but because inflammation is really, really important. If we didn't have these inflammatory processes, we wouldn't get things like wound healing. We wouldn't be able to protect ourselves from infections. But it's getting the balance right. Once our sort of inflammatory process is, the other thing to emphasize is that inflammation isn't like an exhaustive process. It's very tightly regulated, and we need a certain amount of inflammatory products, and we need a certain amount of anti-inflammatory products. And I guess at some point, if you have too much omega-3, then you are possibly at risk of dampening your inflammatory processes to the point where maybe you wouldn't be able to respond appropriately. So that's something to maybe be discussed at some point. But I certainly wouldn't recommend more than sort of 6 grams maybe of long chain omega-3 fatty acids. And if you look at the sort of EFSA, I think it's EFSA or the science committees, they suggest that 5-6 grams is perfect. EPA in itself, sort of 2 grams upwards, is perfectly safe. So trying to define how much is too much, I'm not sure, but you've got sort of I've not come across anything really
Nina,
sort of
from from a sort of scientific study point of view, from a safety point of view, there haven't really been any studies where I are aware of where they've
Yeah.
needed to use more than 5 grams, and that
No.
is considered perfectly safe. But again, going back to this idea of testing baseline levels, we are yet to find anybody who's needed more than sort of 2.5-3 grams maximum of pure EPA. So it's not something that if you are testing, that if you are really trying to make a difference, needs to be a worry or a risk. So the short answer, I guess, is that no, you can't really overdose unless you are willing to spend £100 a day on fish oil, in which case then maybe you can.
Yeah.
But on the whole, it's not very easy. And even the studies that are showing that there are changes in the fatty acid levels, we're still yet to actually see a study that shows if you take lots and lots of omega-3, as Nina said with the case of the Inuits, you end up with major detrimental effects as a result. So whilst it is important to have the balance, it's as yet not considered safe to take lots of fish oil, particularly if you need it. So just to kind of move on, there's been quite a few questions, Nina, about vegetarians.
Yeah.
Obviously, there are different options for vegetarians, but what's the best option for somebody who is vegetarian, strictly vegan, in order to realistically raise their omega-3 index? Does a vegetarian option work? Will we see clinical benefits for vegetarians by using these alternatives?
Right. Okay. Well, the answer to that is that, yeah, I mean, there are veggie alternatives. I mean, most vegetarians will look towards something like flaxseed oil for their intake of omega-3 fatty acids. And in fact, if we just scoot all the way back up just for a minute, we can have a look at where we are. So our vegetarians sort of have an issue with delta-6 desaturase, so they don't manufacture EPA and DHA very effectively. And if they're not sort of consuming marine sources, then they're sort of their levels can be affected. So where do vegetarians get alternative sources? Right. So we've got something called echium seed oil here. Now, echium seed oil is a very unique omega-3 fatty acid supplement or oil, omega-3 containing supplement, because it's very rich in this fatty acid here called stearidonic acid, which binds the rate limiting step of delta-6 desaturase, sorry, and so it sort of shuttles through and converts through to EPA, and then through to DHA, actually, a lot more effectively than ALA, which is our primary omega-3 fatty acid that is found in flaxseed oil, for example. Now, the other sources, obviously, is that you can get algae. Now, currently, the primary algae supplements out there are really DHA heavy. So they're either pure DHA or they're mainly DHA with a little bit of EPA. Now, the issue with that is if we're looking at sort of inflammatory conditions, it's really EPA that we want to be sort of concentrating on. So I would suggest echium seed oil is probably your best bet. Now, the other thing to sort of really take on board is that it's this relationship here that's really important when we're looking at sort of inflammation. So we need to be aware that no plant form will really give the same kind of benefits as a marine source, to be honest with you. But it may be worth just checking your client omega-3 levels out, because they may not actually be as deficient as you possibly think they may be. So without sort of really identifying whether there are deficiencies there in the first place, it's very difficult to comment too much on whether to sort of take echium seed oil or whether to go for sort of reformed DHA, for example. But then there's sort of recommendations about possibly, it's not always just about increasing your omega-3, it's also about decreasing your omega-6 as well. So getting some sort of dietary information from your client as to what they're actually eating, because quite often you find that vegetarians will overcompensate
on the omega-6 side, and there are ways that you can sort of reduce your omega-6, which will have a natural beneficial effect on driving the omega-3 fatty acid pathway up. But we can send you some more information on Arachidonic and seed oil if you'd like. Yeah, bye-bye, Marion.
So hopefully that answers most of the questions. I did post an email address earlier, but if anybody does have any further questions that we haven't been able to cover so far, education@igenis.com will get you through to myself and Dr. Bailey, and we will do our utmost to provide you with whatever information it is you're after. So yeah, it leaves me and Nina, I guess, just to say thank you very much for coming and giving us your time. Thank you for listening, and we hope to see you on next webinar. Have a lovely evening. And
yes, thank you very much, everybody. Super. Cheerio.
Good night.